All right, folks, I'm so excited about today's episode on Healthcare Unfiltered because I have an amazing colleague who is joining my show for the first time. Dr. Pallawi Torka, welcome to Healthcare Unfiltered.
Thank you, Shadi. It's a pleasure and honor to be here.
It's so good to see you. And today is really all lymphoma in and out. And we want to talk a little bit about some of the data that's being presented at EHA or have been presented at EHA 2025 and ASCO 2025. And I say has been because have been because we are airing this podcast after the completion of both meetings, although admittedly for listeners and viewers, we are taping this a couple of days before the ASCO 2025 meeting. But let's start by getting to know you a little bit. So tell us a little bit where you work, what you do, and what got you interested in lymphoma.
Oh boy. Okay. So, as you mentioned, my name is Pallavi. I'm originally from India and I did the initial med school training and also a residency in India. And then when I came to the US, I've pretty much been a New Yorker my whole life, as in not New York City, New Yorker, but just living in New York State. Did my residency and fellowship, SUNY Upstate in Syracuse, and then at Roswell Park in Buffalo. And then I've been at Memorial Sloan Kettering Cancer Center for the past 2 years. I've been involved in lymphoma, care of patients with lymphoma and research in lymphoma for about 10 years now, starting from when I was a fellow. And I tell you, there's no better job satisfaction than telling a patient that, we can cure you and then finally giving them the good news that we are cured. And that's what fuels my passion for doing what I do.
Was there a specific mentor or someone or an incident that made you kind of migrate into lymphoma, or was it like always blood cancers were since you were in India?
That's what they ask you all the time when you have to write your residency application. What is your, I just don't know. I just remember my parents saying from when I was 3 years old that I always wanted to be a doctor. And then when I was doing my fellowship, I guess I thought the coolest people were in lymphoma. My mentor, Dr. Francisco Hernandez, he was just a great teacher. And so I started working in the lab with him and it was just fun. So I feel like
Yeah.
that's what drives me to lymphoma is it's not just job satisfaction, but it's also fun for me.
And Pallavi, are you mainly a clinician? Do you have any lab responsibilities? You just work with the lab people, but or
Yeah,
how?
no. So I'm a clinical investigator and educator. So I used to be in the lab, but now it helped me because I know lab speak and I can understand the language, but I don't work in the lab anymore. I am involved in clinical trials, all phases, phase one, two, three. I'm also very interested in outcomes research, observational studies, and more recently, my research focus has been geriatric hematology. So I want to try and bring novel therapies to the forefront and see how we can use that to improve care of our older adults with lymphoma.
Oh boy, now when people say geriatric, I get scared because I'm up there now. But
I know.
Memorial is such a big place. Are you specifically focused on B cell? I know obviously like Steve and others do T cell. Is your area specifically B cell lymphomas?
I would say predominantly yes, but with my interest in older adults, it's more cross-sectional rather than focused on one particular cancer. So my investigator-initiated trials are in aggressive B-cell lymphomas, and we did publish our nivolumab-AVD in older adults with Hodgkin lymphoma study because those are the unmet needs. For T-cell lymphoma, I've not really ventured in that area because everything in T-cell lymphoma is an unmet need.
Right.
So, focusing on things where we can make an impact first and then maybe start working on T-cell lymphomas.
And I just to make sure for my listeners and viewers to know that we're going to focus today's podcast on B cell lymphomas specifically, maybe with a twist into the aggressive type of lymphomas, depending on what you pick. So, folks, I've asked Dr. Torka kind of a bit of a challenging ask, but she's up for it. I said we're going to try to give a concise, selected abstracts that may have clinical implications coming from ASCO 2025 and EHA 2025. And obviously, there are thousands of abstracts get submitted, maybe hundreds get accepted. So it's no easy feat, but we appreciate you telling us what piqued your interest. Let's start with ASCO 2025 Anything specific in lymphoma that we should be aware of?
Yeah, so I would like to start with just apologizing to my colleagues who submitted great work, and it may have been accepted as a poster this time because, as you mentioned, it was hard to go through every single one. So I tried to focus more on the plenary sessions and the oral abstracts. But for anybody who's listening to the podcast, if they feel like we missed out on mentioning their work, please feel free to comment and share, and we would like to learn from you. Um, so starting first with ASCO, ASCO was a little bit light on lymphoma this year. Um, I am just scrolling down to find my ASCO list here. All right, so and here I'm actually going to combine both ASCO and EHA because it's the same theme. So what I'm talking about is the 2-year follow-up on the STARGLO study. So for our listeners, STARGLO study is basically a study evaluating glofitamab with gemcitabine and oxaliplatin in patients with relapsed refractory diffuse large B-cell lymphoma. And this was a phase 3 randomized study where glofit GEMOX was compared with GEMOX. Why I want to start with this study is because there was just an ODAC hearing about this particular study and whether glofit GEMOX should be approved in the US based on positive results from the STARGLO study. So actually, the STARGLO study did show that there was a progression-free survival benefit and an overall survival benefit with the addition of glofitamab to rituximab and GEMOX.
Just to back up a little bit, tell us a bit about glofitamab. Just how does it work? Like, why is it so different?
So glofitamab is a bispecific antibody, and so we are all very used to giving rituximab, obinutuzumab in our practice, which targets CD20. Glofitamab basically targets CD3 on one side and CD20 on one side, so it is more potent. And in terms of adverse events, it has cytokine release syndrome and neurotoxicity, which is kind of unique to this class of drugs. It is already FDA approved in diffuse large B-cell lymphoma for patients who have had 2 relapses in the past. And to be honest, we have been using it a lot for our patients who are either not candidates for CAR T cell therapy or whose disease has come back after CAR T cell therapy. And I think it's found its place in our treatment algorithms as a solid third line option. So the premise of this study was to see if we can extend the benefit in the second line setting for patients perhaps who are not CAR T candidates and who are being treated with rituximab GEMOX. So can we maybe improve upon rituximab GEMOX because there was a real world analysis from, I believe, Sam Yamsham, one of our colleagues, who showed that the overall response rate and complete response rate with glofit GEMOX was very, very poor, about 10 to 15% in this setting. So that area is what is a high unmet need is, okay, if your patient cannot get CAR T in the second line setting, or if their disease comes back after that, what can we do for them? And that's why this study was designed to address this gap.
So this was glofitamab R-GemOx superior to R-GemOx in second line setting with progression-free survival. Are these patients, if they're not eligible for CAR T, could they still undergo transplant, or they're not eligible for transplant also?
They're not eligible for transplant also. And just
Got it.
a minor correction, it's R-GemOx versus glofit GemOx. The trial
Yeah,
did
sorry.
drop R in the,
Yeah, of
which is
course.
confusing because some studies do include R and some don't. This one just chose not to have R in there.
And you're saying this is being presented at ASCO and EHA?
No, this is being presented at ASCO, and the
Got it.
study has been presented in the past. This was a 2-year follow-up, and it did continue to show OS and PFS benefit, but I brought it up because it did not get approved in the US because the ODAC committee said that the representation of American patients was very low in the trial.
Interesting.
Yes, which is very unusual for
Yeah, but
for
that's
a
really
decision like that.
interesting.
But we have been using this regimen already in our clinical practice,
Yeah.
and I know in many other centers it's being used. The problem with glofitamab is that there is a ramp up to it. So patients don't see the full dose till about 3 weeks later. And as we all know, diffuse large B-cell lymphoma is a very fast-growing malignancy. So we tend to lose some patients in that time frame. So when we saw this data initially, we were kind of excited because by giving some GEMOX initially, you slow the pace of the disease enough that glofitamab can act.
Yeah.
So most of us have been using this data to kind of start out like that, but then we drop oxaliplatin for sure, and in many cases gemcitabine, and just continue the glofitamab.
Great paper. Next.
Okay, so I'm going to go back to EHA now. And why I started with glofit GEMOX is because the plenary at EHA is the POLARGO study, which is polatuzumab R GEMOX for exactly the same indication. And this is also a phase 3 randomized trial, which is studying R-GEMOX versus Pola R-GEMOX. So interestingly, this is the only one of the very few abstracts where they haven't released the abstract. The abstract is also embargoed. I just know that this has been picked up for a plenary. So I really don't have the data to share here, but I'm assuming that it is good for them to choose it as a plenary. So it'll be very interesting to see the ex-US versus US enrollment and what was the margin of benefit with polatuzumab in this setting.
So this is R-GEMOX versus Pola R-GEMOX.
Correct.
And it's the same exact setting, like relapse.
Same exact setting from what I can get from
Yeah.
just like prior data and all that kind of.
Very interesting. So yeah, we'll have to look forward for this. By the time this airs, obviously it will be out. Like you said, if it's although you know what, we never know. Sometimes plenary session could be because it's a negative study, but I'm with you. I think it's more likely than not it's a positive study.
I'm pretty sure it's a positive study. And again, all these trials, just as general, Pola R-GEMOX versus R-GEMOX. But there should be a third arm, which is just Pola R or something like that, because that's what we do in clinical practice is we tend to use, like how we have an approval for Pola BR already, which is polatuzumab, bendamustine, rituximab, but we tend to drop bendamustine from that. So while these trials are very relevant internationally, for our patients, I do feel like a third arm, which is chemo light, where we maybe drop chemo early, is more relevant in clinical practice, but we do extrapolate the data from all these trials and help them, and these help get approvals for these drugs.
Is the GEMOX arm being explored because this is the most common kind of like chemotherapy backbone that you're using in this setting?
No, I think it's a straw man control. That's why it's being used, because your control arm is so poor that no matter what you add to it, you will show benefit. So personally, I use GEMOX in just as a bridge to CAR T-cell therapy, because let's say if you have a patient who got Pola R-CHP or even R-CHOP, and then their disease comes back within a year, you want to get them to CAR T-cell therapy and you need just a bridge. If they already saw polatuzumab, you're not sure how much it'll work. So in that setting, you don't want to use a bispecific antibody, well, because it was not approved. So we would use GEMOX. Now with STARGLO data, we've been using some glofitamab 1 or 2 doses while these patients are getting ready for CAR T. So that's where I've been using GEMOX the most. In the third line setting, we can use GEMOX in patients who are not eligible for anything else, but we have so many other drugs, tafasitamab, lenalidomide, loncastuximab. So I feel like GEMOX is being used less.
The reason I asked is because you just mentioned, obviously, like, the BR, right? The BR regimen in relapse disease, and you've got the Pola BR versus BR, and we know that Pola BR is superior. And to me, this seems like it's doing the same trial just with a different chemotherapy.
Yes. Yeah.
Okay. Next.
One more thing I will mention though is there is data that gemcitabine does potentiate immunotherapy. So there's some biological rationale about adding gemcitabine to all these trials with bispecific antibodies to kind of boost response.
Okay, that's very nice to know. All right, next.
Okay, next.
See, it's rapid fire. That's fun.
Yes. So next is a trial which was it wasn't on my radar, but it's a very relevant trial, and it is a trial in T-LGL. So
Okay.
T-LGL is a very rare disease. However, it's very frustrating to treat because you either use methotrexate or cyclophosphamide, and you just kind of give it for months and months, and you don't know which one works. And we were taught in fellowship that if patient has more neutropenia, then you use methotrexate. If they're more anemia, you use cyclophosphamide. But Dr. Lamy and colleagues actually did a randomized trial of cyclophosphamide and methotrexate, and they were able to prove that for sure cyclophosphamide is the way to go. So based on this randomized trial, I think my practice is kind of shifting more towards cyclophosphamide for any patient with T-LGL. So
You know
like,
what's
oh,
so
start
what's
T-LGL.
what is so funny when you're mentioning this, Pallavi, is that I mean, obviously for listeners, this is a rare disease, but when you do enough lymphomas, you see enough of it at least. I've always used methotrexate.
Yes, me too. And I feel hesitant to use cyclophosphamide because I'm just not comfortable with. But apparently, based on this study, you got to change, Chadi.
So they can use like just oral Cytoxan?
Oral cytoxin, you start with 100 milligram, and then you have to drop the dose to 50 milligram after, I believe, 4 months per the study.
Okay.
This is
I
how you
mean, and you know, I mean, obviously some patients with LGL we can observe. I mean, we don't have to treat sometimes every LGL, right? You observe few patients
Oh,
here
yeah,
and there.
yes, yes, absolutely. This is only when they
Yeah.
need to start treatment.
Okay. Moving on. We're doing
Moving on.
good. 3 abstracts so far.
So these were the trials that are really like sort of practice changing. The others are just provocative, but I don't think really, from what I can remember, there was anything super practice changing. A very provocative abstract going back to diffuse large B-cell lymphoma, and my favorite topic, DLBCL in older adults, is the R POLARGO. It's called the POLARGO study, so POLARGO, POLARGO study. And it's a very bold trial because, so this is a large study again by the Austrian German Lymphoma Alliance. And what they're doing is they're just doing away with chemotherapy. So it's just polatuzumab, rituximab, and glofitamab, coming back to glofitamab, in patients with newly diagnosed diffuse large B-cell lymphoma who are not candidates for full dose R-CHOP. So they have reported preliminary results of the study, and so far, let's see, these patients are
So,
old.
so one question as we're talking about this, you know, you are really doing a lot of work in older adults and you're focused on that. How are we defining these older adults? Because sometimes, you know, I mean, again, you're the expert. People are saying, well, you really can't use age. You should like comprehensive geriatric assessment and things of that nature. In this study specifically, how to define it, but also in your practice, how are you defining older adults?
Okay, so like this podcast is not going to end now in 30 minutes or so.
No, no, it's
That's like
it's
my topic. But
yeah.
in a nutshell, you're right, age is not the only criteria. So we need to do some sort of functional assessment, and we know that geriatric assessments, while like they're the gold standard, they're the Rolls Royce, we really don't have time in clinic. So that's what part of my research is, to use something like cheat sheets, smaller measures. Like I'm doing a lot of work in timed up, to look at timed up and go, and kind of use it as a fifth vital sign. It's easy to incorporate and to see how we can decide on treatment based on that. But based on the data we have so far, we know that patients who are more than 80, they do as well with mini R-CHOP as R-CHOP. And in fact, they have less toxicities and better quality of life. So for those patients, we know mini R-CHOP is the way to go. For patients who are between 70 to 80, it's a judgment call. But what we also know is eyeball test is not enough. You need to incorporate some sort of data. So in clinical trials, at least we are doing simplified geriatric assessment, um, which takes about 10 minutes. But to be honest, I don't do it in my practice. I still kind of eyeball, but this might change with some more data that we are publishing and other groups are publishing. But the whole truth is that all studies have shown that at, regardless of age, if you treat with curative intent, so even if you give our mini chop to a 90-year-old, they fare better than giving something which is not curative, like just rituximab or CVP or anything like that. And there's a stark difference. So never just let age be the defining factor. Even if someone is 90 but they have a good ejection fraction, try to give them mini R-CHOP or something equivalent. But that's why this study is important, because is we have so many new drugs, and not quoting too much data, but we know that all these new drugs that have come out, tafasitamab, lenalidomide, Lonca, bispecifics, they don't really in older adults, they don't really have worse outcomes. Like they have a very favorable risk benefit profile. So why not use these new treatments upfront and maybe get away from chemotherapy in this population? And that's what people who work in this space are trying to do. It. I have a clinical trial which is similar, but I really want to applaud this group because they really, for better or for worse, like this is a really pioneering kind of trial where they just did away with chemotherapy completely.
And
The
this is a
problem
phase 2. This is just a one-arm study.
this is just a one-off, and that's one problem. But the other problem, my criticism of the study is they left it to the eyeball test. So, like in the protocol, they just say, oh, if a patient is ineligible in the eyes of the physician above 65 years age, then they go on the trial. And we know from data that R-CHOP or R-CHOP equivalent mini R-CHOP has the best outcome. So for such a bold trial, I would have loved to see some formal measures saying, oh, they can't get chemo at all or something like that. But within those confines, they have reported the response rates, which are excellent. So the overall response rates was 90% at the end of treatment, and the complete response was 82% after just giving the 3 drugs for a total of, I believe it's 12 cycles of treatment.
Very interesting. Yeah. I mean,
Yeah.
I also think, 65 is it's just
It's,
not that old.
yes,
Even
exactly.
if you just use the age. I mean, I
Yes,
realize
yes, yeah.
maybe it's
But
because,
yeah, yeah. No, it's because like 65 is truly not that old. Like I think of, I'm not 65 yet, but my parents are that age and, in their 70s. And I feel like, yeah, they can get chemo. I
yeah,
don't.
that's why I really believe this. What you're doing is amazing. Being able to find something that is so practical in clinic to use instead of the comprehensive geriatric assessment is going to be key. I will always contend that you have to make it simple for clinic and workflow and so on. Great selection. What else do you have for us?
Okay, so let's see. I am going to switch gears to Hodgkin lymphoma.
Okay.
Uh, and Hodgkin lymphoma, do you have international, I'm assuming you have international viewers of your podcast too.
Yes. So speaking of which, the most people who are Canada is number 2 after the US. I have UK a lot, and I have Turkey a lot. And then you have some again, there's like a whole analytical thing. But yes, I do have international viewers and listeners.
So for Hodgkin lymphoma, there's a big debate, right? In the US, we have adopted nivolumab-AVD in the front line universally, and we love that regimen. It's easy to give, very high response rates, great progression-free survival, and overall survival about 88%. Um, with in Europe, though, their favored regimen is Briocad, which by far is the best regimen for Hodgkin lymphoma. But in the US, we are a little bit hesitant because it is a little bit more toxic, and the overall response rates are similar with both Nivo-AVD and Briocad, but the progression-free survival is definitely better with Briocad.
What is the EU regimen? Which one again?
So it's called BRECADD. So if you remember, people might remember that Biacop was the original regimen. So because Biacop was really toxic and really intensive, the European groups modified Biacop. They added brentuximab. They dropped, I don't remember exactly the regimen, but like basically they shortened the number of days and they dropped the duration of steroids to make it much better tolerated. And it was. And so there's never going to be a randomized trial between Nivo-AVD and Briocad, but uh, this group did kind of like a indirect, a meta-analysis and an indirect comparison with individual patient level data of the 2 regimens. And again, it doesn't give you the full answer, but it tells you that, well, first of all, Briocad is very toxic in patients over 60. So we're not talking about patients over 60. For them, Nivo-AVD is the way to go. But for patients less than 60, they did find that PET-adapted Briocad did lead to a better and sustained progression-free survival, although the risk of febrile neutropenia was higher in Briocad. So by far, Briocad is the best regimen. This is the best data we are going to get. of comparing the two regimens, and BRICAD is the best regimen for patients less than 60. I don't think it'll change our practice in the US because again, you the overall survival is similar and nivo-AVD is just so easy to give. And when we are talking about difference in PFS, we are talking very minor differences. Like the progression-free survival with nivo-AVD is over 90%. It's like 92%. With BRICAD, the progression-free survival is let's see, 94%.
But
So
this is not a prospective randomized study. In all fairness, I know what you're saying is that the BRICAD is better than NAVD based on this trial, but this
yeah,
is
it's not a
it's a
prospective. Never is the
meta-analysis of
meta-analysis.
yeah.
Yeah, yeah.
Uh,
And the other exciting thing about Hodgkin lymphoma, which is not ready for clinical practice, but for anybody who's taking care of Hodgkin lymphoma, is we have this crisis, sort of, is we are giving nivo-AVD to our patients in frontline or BV-AVD, and then we are using up nivolumab in second-line setting. So even though this is a very small subset of patients, the question is, what do we do for our patients who progress, unfortunately, after both? And there was really nothing that was showing good outcomes. Initially, CAR T cell therapy, anti-CD30 CAR T cell therapy in Hodgkin was very promising, but it led to less than optimal results. The progression-free survival was very short. Most patients were relapsing within 1 year. So there is this new concept of AFM13, which is essentially a tetravalent, it is a bispecific T cell engager again, which combines CD30 with CD16. So instead of activating T cells, it's activating NK cells. And it's being combined with allo NK cells. So instead of relying on patients' own NK cells, we are making a package of this AFM13 and allo NK cells and giving it to the patient. Preliminary data, but really good data. So I think if anybody has a patient in that tough situation, I personally think it's worthwhile to refer patients for these trials wherever they're happening. And the study is called, it's a very cool name, LUMINI study. What they've shown is that the overall response rate is 80 to 100% in different subgroups and different like dose finding subgroups. And the complete response rate is around 55 to 67%, which is really good data considering the type of patients that are being treated in these studies. So I thought that was a very provocative abstract, something to really take home from the EHA meeting.
Amazing. What else do you have for us?
Another encore abstract. So this is, I'm going to switch gears again because we have so many lymphomas and that makes our job interesting.
Yes.
So switching gears to follicular lymphoma. So this is data that was already presented at ASH, which is the phase 3 inMIND study, looking at tafa, len, rituximab in relapsed refractory follicular lymphoma. So background for the study is we are already using lenalidomide and rituximab in relapsed follicular lymphoma, and also even though it does not have an approval, we sometimes use it in the frontline setting too. The progression-free survival, I believe, is around 11 months with rituximab and lenalidomide in the relapse setting. So this was a randomized trial which added tafasitamab to the combo. So it's a randomized study of rituximab len versus tafa rituximab len. And there was a progression-free survival benefit, which is sustained, and there's a trend towards overall survival benefit. Where is this? So they have applied for registration based on this study, and that's why I wanted to talk about it, is because this might be an option that might be available later in the year for our patients with relapsed follicular lymphoma.
Is there something specific about TAFA that makes it more applicable to indolent lymphomas versus aggressive lymphomas?
I really don't think so. I think the expression tafasitamab is an antibody that's based on CD19 expression. The company just prioritized approval in approval in diffuse large B-cell lymphoma first, based on the phase 2 inMIND study. But there's no reason why this drug may not be active in indolent lymphomas. So this was their second foray, looking at TAFA in follicular lymphoma, essentially.
Yeah.
I will tell you it's a little less attractive in follicular lymphoma because of its administration regimen. It's given weekly for 12 weeks, and then it is given every 2 weeks for the rest of 9 cycles to complete 1 year, which is a little bit demanding for our patients to come that frequently for their appointments.
Yeah. It's interesting. I mean, the follicular lymphoma is one of those diseases when things are working, it's a very easy disease to treat and it's very satisfying. But gosh, some of these aggressive follicular lymphoma, not transformed, just the follicular lymphoma that you try and nothing is working, they're really very frustrating to treat, unfortunately. So having these options is very helpful. What else have
Yes.
you got?
All right. Again, we'll switch gears.
I like
Talk
switching gears.
about marginal zone lymphoma.
Marginal zone.
So this is so it ASH and ASCO and EHA, all these have been pretty much ruled by bispecific antibodies in the last year or two. So this is another bispecific antibody trial, which is looking at mosunetuzumab in the frontline setting in marginal zone lymphoma. Why is this relevant? Is because mosunetuzumab already has an approval for relapsed refractory follicular lymphoma. It has no other approval in any other disease yet. There was my colleague Lorenzo Falchi from MSK presented really great data on frontline mosunetuzumab in follicular lymphoma. Like we're talking about overall response rates of 95%, CR rates of 70%. And similar data is being reported for marginal zone lymphoma, where just mosunetuzumab, time-limited single agent, is doing very well for frontline marginal zone lymphoma. So I don't know if the company will go for registration based on this data or if they have plans to develop it in the future, but it just goes to tell you that personally, I feel like chemotherapy is going to go away soon for many of these diseases, and we're going to use more of these immunotherapies for
So
these.
this is frontline.
This is frontline. Yeah,
Yeah, yeah.
yeah,
Interesting.
yeah.
Um, okay. What else? Because I do have some questions later on.
Um, so I think pretty much one more trial I'm going to mention, and this is again something which I think I find it super cool, and this is not a drug at all. I'm talking about phase-seq, which is circulating tumor DNA in diffuse large B-cell lymphoma. So we don't have any approvals for ctDNA or MRD testing in DLBCL. The only in any lymphoma, I mean, the only MRD testing that is approved is clonoSEQ, which is totally different technology. So phase-seq is by far the best technology we have so far. And it is really discriminatory in terms of outcomes. When phase-seq is done at the end of treatment, if your patient has negative phase-seq, regardless of PET scan, in diffuse large B-cell lymphoma, those patients have very low likelihood of a relapse. And I think the converse is more important, is even if your patient has a negative PET scan, but their phase-seq is positive at the end of treatment, their progression-free survival was like 30%. So they are at very high risk for relapse. And I think this is really cool technology because once these patients relapse, their chance of cure goes down quite a bit. So, this opens up this whole area of trying to intervene early and, try to salvage patients even before they have a frank relapse. But also the reverse, can we leverage this technology to give less treatment? For example, if phase-seq is so powerful, then can we do it after 2 cycles of R-CHOP or Pola-R-CHP? And if they're already negative, maybe in the future we can give less treatment to many of our patients, especially like I focus on older adults, and who wants to give them 6 cycles if we can get away with doing 4 cycles or even less?
Very
It's
interesting.
more data that is being presented, and it's prospective validation of phase-seq in diffuse large B-cell lymphoma.
That's a lot. You gave us a lot. I really
Two
appreciate it.
conferences, so that's a lot.
Yeah, no, but I mean, and these, I mean, I think you mentioned the first couple of abstracts we talked about are probably have clinical application. Some of the others are interesting. I mean, I think the NAVD one, I mean, just a couple of questions, Pallavi, like the NAVD, what you mentioned is specifically for advanced stage disease.
Yes.
Um, what are you doing for early stage? I mean, I think because the results are so good, like the bar to improve on things is a little bit harder. But how are you approaching early stage disease right now, the favorable early
Yeah.
stage?
Yeah, because that's what I was going to ask. Early stage, favorable, unfavorable, bulky.
Right.
So I am it depends on whether you are an early adopter or a late adopter. I usually tend to wait for the data to mature before I change my practice. And as you mentioned, the bar is really high. So I still do either, 2 cycles of ABVD, and if patients are in remission, then depending on the location, I either give 20 gray of radiation, or I continue with 2 more cycles of ABVD per the UK rapid study, and so on. Um, there is data that even 3 cycles are enough. You don't have to do 4 cycles of ABVD, but the PFS was slightly less if you did only 3 cycles. So I still stick to 2+2. I don't usually use novel treatment, brentuximab or nivolumab in that setting. We do have the radar study, which is studying this scenario. And in those patients, it's exactly RATL, but not RATL, but it's exactly like you use BV-AVD and in for 2 cycles, and then if patients are in remission, then you do 2 more BV-AVD. But outside the trial, I haven't adopted that at all.
I mean, I ask because, I mean, for me, I mean, I don't know, like I always wonder, I mean, I think bleomycin is such an ugly drug and it's like an old drug. And, if you have these side effects for some patients, it's very, very challenging. And it makes me wonder, why not use NAVD or AAVD in the earlier stage? I realize the data is very scarce. I understand that, but it's a fair question, I think.
I absolutely agree with you. But again, similar to bleomycin, nivolumab is also kind of like a wild card. Most patients
Sure.
do totally fine with nivolumab, but I've presented, like when I presented Nivo-AVD study to many patients, they hesitated because when you mentioned that, oh, you're probably going to be fine, but there is a small risk that you might have an
Right.
immune toxicity and we don't know what it'll hit, then patients are like, so there are some things that
Sure.
we can't
Sure.
control about checkpoint
Hey,
inhibitors.
look, I mean, anything that we do, there's
Yes,
no free lunch.
there's no free lunch.
Anything that we do, I mean, hey, we use adriamycin. I mean, have you had CHF after one dose of adriamycin? I have.
No.
I
Oh,
have
yeah.
one time. But that's one patient, only one patient.
Scars you.
You never forget, really. I mean, obviously, you use hundreds and hundreds of patients, but that one person, because you tell them always that it's dose cumulative, all of these things, but the reality is CHF could occur with
Yeah.
the adriamycin after one dose. The other thing I was going to ask you, and I promise I'll let you go. You're on the inpatient service, and you probably have better things to do. But CAR T, um, we have grown to learn that we use CAR T in early relapse and BMT in late relapse, in first line relapse in DLBCL. Any data on CAR T? Like there are so many CAR Ts out there. Any better constructs in this situation, like selection? Put your hat on, again, the general oncologist and so on. There's so many of these out there. Is there a reason to select one versus the other in early relapse for CAR T? And I was going to ask you, my second question is there anything happening in the world of CNS lymphoma?
Yes. So CAR T question is easier. And personally, I don't deliver CAR Ts. I'm in the same shoes as a general oncologist where I identify our patients and refer them. But my personal opinion, just looking at all the data at a very high level, is Lysocell. It has probably the best balance of risk versus benefit. The response rates and PFS is as good as Axicell with less cytokine release syndrome and less neurotoxicity. Granted, Lysocell trials were done a little bit later, so we had developed kind of know-how about how to manage these, which might have colored how these patients were managed. But I know we prioritize Lysocell in our older patients. The third drug, Tisacel, is usually reserved for indolent lymphomas because while it has a great safety profile, we feel like the outcomes are less than optimal for our aggressive lymphomas. Answering your second question about CNS lymphoma, very, very tough space. I think methotrexate still rules, high dose methotrexate still rules the roost. This is one space where CAR T cell therapy has not
Does
delivered.
not, yeah.
In the relapse setting, we are still referring our patients, but I don't know if we are doing a service to them. I mean, we're just doing it because we don't have anything better to offer them.
Yeah.
And rarely they are sustained responses, but this is a huge area of unmet need where even in our youngest and fittest patients, we are not able to deliver the high level care. And for our older patients who are not a candidates for methotrexate or auto, it's really tough to give them sustained responses. We have a ton of drugs, lenalidomide, ibrutinib, um, tirabrutinib is being studied in clinical trials and is showing some promise. So there are a lot of drugs which produce response, but not truly produce a cure for our patients like that. Just one last word is radiation. We should not forget radiation. Uh, I know we were initially historical data showed that radiation causes dementia and long-term neurocognitive impairment. So we were kind of shying away from radiation in CNS lymphoma, but I do think that's one of the strongest treatments, best treatments to achieve a cure that we have in CNS lymphoma.
This is amazing. This is like a whirlwind of lymphomas across ASCO 2025 and EHA 2025. Any other questions I should have asked you that I completely forgot or missed that you think of relevance to our listeners and viewers?
I think that was plenty. And then if I think of something, we'll do a second podcast.
Excellent. Dr. Pallavi Torka, thank you so much for coming on Healthcare Unfiltered. I really appreciate your time.